Today we have the free paper session and Dr. Chetan Kumar is there? It's not there. Okay, who's next speaker? Sanjay Kumar Giri? Not there. Dr. Jawahar T? Not there. Dr. Pratibha Rana? Not there. Dr. Shubham Sharma? Not there. Dr. M. Akash? Dr. Navneet PK? Not there. Dr. Mohammed Ibrahim BK, please. We'll start off with reconstructing fingertip defects with inverted reverse flow digital artery flap, a case series. Dr. Mohammed Ibrahim BK, please.
Thank you, respected chairpersons, delegates, and dear friends. So today I'll be talking about our series using renovated reverse digital artery flaps for reconstruction of fingertip defects. So fingertip injury is one of the commonest injuries that we encounter as hand surgeons, and homodigital sensate glabrous flaps like VA advancement or oblique triangular flaps are the ideal option for reconstruction. So as they provide sensate glabrous skin. But sometimes the defect characteristics and geometry preclude these options, and various options have been described for such scenarios like the cross finger flap and the thenar flap. And the disadvantages of those options are that it involves violating an adjacent finger or a contact surface of the palm and lack of sensation. So reverse digital artery flap is a homodigital island flap. It is based on a reverse flow in the digital artery, and the vascular basis is through the communicating branch between the two digital arteries. There are almost 6 communicating branches, and this flap has been described on the middle apex communicating branch. It can provide a partly glabrous skin cover because the flap lies in the junction between the glabrous and non-glabrous skin, and the secondary defect is usually covered with an FTSG. So the ideal defect for a reverse digital artery, homodigital reverse digital artery flap would be defects involving the pulp or a fingertip amputation that involves the terminal phalanx. The defect should not extend beyond proximal to the PAP joint, and there shouldn't be any proximal injuries. So these would disrupt the communicating branches and would make the flap impossible. So it can be harvested along with the dorsal branch of the digital nerve, which can be innervated by anastomosing to the digital nerve stump, providing a sensate skin cover. In the classical description, the digital nerve is sacrificed, but in our technique, we make sure that the digital nerve is preserved. So coming to the operative technique, the flap is marked on the side of the proximal phalanx of the side of the finger that is closer to the defect. Flap lies at the junction between the glabrous and the non-glabrous skin on the proximal side of the proximal phalanges. An exploratory bidaxial incision is made and the neurovascular bundle is identified. The dorsal branch of the digital nerve can be easily identified going into the flap. This is dissected proximally intraneurally, and it is divided and it is included with the flap. The digital nerve is separated from the neurovascular bundle by dissecting in the perineural space close to the nerve. So this is a key point because this preserves the small veins which accompany the digital artery and which provides the venous drainage of the flap. The digital artery is then divided just distal to the bifurcation of the common digital artery. The flap incision is completed and raised. The digital artery and the periarterial venous plexus till the mid MPX region. The flap is then transposed into the defect. The dorsal digital nerve, which has already been included in the flap, is usually anastomosed or connected to the opposite side digital nerve stump. The secondary defect is then covered with an FTSG. So in our series, we had 10 patients who underwent the RDA flap. So all flaps survived without any partial or complete loss. And on long-term follow-up, the average 2-point discrimination was 4.2 with a range of 5 to 8 mm when compared to the contralateral finger, which is 2.4 with a range of around 2 to 6. 2 patients had minimal hypertrophy of the donor site and without any contractures. So a few representative cases. So this patient actually had a 2-finger injury. Ring finger he underwent VA advancement flap, and the mid finger he underwent the RDA flap, which was innervated at 24 months follow-up. So this is another patient with an early post-op result at 3 months follow-up. So another patient with an index finger injury with a late post-op result. So the only problem that we usually encounter is the mid-axial incision which is placed sometimes encroaches upon the palmar aspect, and this can lead to a little hypertrophy. So this we usually manage by making sure that the mid-axial incision stays dorsal to the axis and by vigorous physiotherapy and scar massage. So this is another patient again with an oblique amputation treated with an RDA flap. So the take-home message would be an RDA flap is a reliable option for fingertip injuries and amputations. An innervated RDA flap provides stable, sensate, well-vascularized skin cover with minimal donor site mobility. Thank you.
Good presentation. And most of the cases which you have shown, you have taken from the bordering digits like index finger and little finger.
Yes,
Have
sir.
you had any case of vascular problem? Because as you know, index and little finger has got a single major artery, and that artery you're taking it off.
So what we usually do is that before dividing the digital artery, we put on a soft clamp and release the tourniquet. Always ascertain that the vascularity is adequate even after clamping the proper digital artery. And we haven't had any problems with the vascularity of the finger as so far.
Okay. To add more value to this study, maybe there are a lot of fingertip functioning scores have come.
Yes,
So
sir.
if you are aware of it, if you add that, no, it adds value to it.
Yes.
Yeah, thanks.
Thank you.
Good morning, everyone. So I'll be sharing my experience on management of pink pulseless sand, that is the early vascular exploration of pink pulseless sand in supracondylar fracture of humerus. Also, I'll be correlating the intraoperative findings with the preoperative clinical findings, also emphasizing on the predictors of vascular repair. So collective incidence of neurological and vascular compromise is 10 to 20% in case of displaced supracondylar fractures. Coming to the management, it is the urgent close reduction with a cast followed by KY stabilization. Most of the cases, the radial pulse will return immediately. If not, we categorize into pulseless warm, the well perfused pink hand, and other is the pulseless white hand. So there is no, so the management of pulseless white hand is which warrants early vascular exploration, immediate vascular exploration. Whereas coming to the management of pink pulseless hand, there is a conflict in the literature. There are two schools of thoughts, which says watchful waiting, other advises early exploration. So here it was a retrospective review of 4 cases of pink pulseless sand which were treated with exploration of brachial artery by a single plastic surgeon in tertiary care center between 2021 to 23. So in all the cases, initial cast application by referring orthopedic surgeon had failed to re-establish the distal pulses, which was confirmed with a Doppler study. So brachial artery was explored in all the cases, and the fracture was then stabilized with the K wires. So among the 4 cases, we noted there was involvement of the medial nerve in 3 cases, and in one of the case, there was a tethered artery was noted and also the nerve. So mere surgical release sufficed to re-establish the blood supply. Whereas in other 3 cases, there was a morphological damage which was noted to the brachial artery, and 2 of the cases we had to put an interposition vein graft. Whereas in other case, after doing a Fogarty's thrombectomy, so we couldn't re-establish the blood flow, so we had to do bypass vein graft. Here we can note the compression of the artery, and there is a segmental occlusion, and also good distal runoff is seen. So in most of the cases, they bet on the collateral circulation, so entrapment of the artery. And in this case, there was a long segment of brachial artery was injured even of the arteriotomy and the thrombectomy. we couldn't re-establish the blood flow. We had to do interposition vein graft. And here in this case, the long segment of injury to the brachial artery, and also there was a calibral discrepancy during the anastomosis, so we had to do a bypass vein graft. In most of the cases, we had used the basilic vein for the interposition vein graft, whereas in some cases less than 3 years and 4 years, the caliber of great saphenous vein, which was harvested, found to be of small caliber, so we had to go with a basilic vein. So coming to the early follow-up, in some of the cases, in the case of the bypass vein graft which was put, so we noted surprisingly the good blood flow even through the brachial artery also, the native brachial artery. So to conclude, we recommend early surgical exploration of all cases of pink pulseless sand with a coexisting neurological deficit for good outcome, especially in the background of late arrival, that is more than 8 hours after the cast application to the operating table. So in 3 or 4 cases, there was anatomical damage to the arterial valves causing tear or intravascular thrombosis with a median nerve contusion was noted. Failure to restore the pulsation even after 8 hours following close reduction suggests arterial compromise as opposed to vasospasm. So neurological sequelae is potentially more important than the vascular consequences. Entrapment of median nerve likely to be a permanent damage. So there are two school of thoughts. Those who are in favor of early exploration, they say it will result in patent vessel if we explore and the damage is permanent, and some have recorded the reduced diastolic blood pressure as compared to the opposite limb and the stenosis of brachial artery and forearm claudication on exercise. So those in favor of early exploration, they say collateral circulation is variable and unreliable, and it will lead on to irreversible Okmas ischemic contracture, and it will, if you don't explore, it will also incur unnecessary fasciotomies. And those who are relying on the watchful waiting, they rely on collateral circulation, and if you don't, even if you explore also, there is high rate of symptomatic occlusion and residual stenosis in coming days. Thank you.
So the one case which you saw that the median nerve was entrapped, do you think that nerve could have been, if they had reduced it closed, would that tether would have been released, or it had to be surgically released?
Sir, chances are there, but since the baby is under anesthesia, so both the surgeon and the plastic surgeon and orthopedician, we are working together. So we have always an opportunity to explore. It will give an additional incision, that's all. So I advise to, if the median nerve clinical neuropraxia may be neuropraxia, it's better to explore.
Okay, thank you.
Dr. Chetan, so what is your take-home message? Should we explore or not?
We should explore, sir.
Should explore, right? You have done any pre-op CT angiogram or anything to make sure?
In some of the cases, sir, it's more of waste of time. Will be better
Waste
to
of time,
go ahead with.
hardly CT angiogram is 3 to 5 minutes.
Yes, sir. We can go ahead with a clinical findings pulsation if it is absent. Also, the pulse oximetry we should more reliable, sir.
Yeah,
If
that's why.
waveform is not there, we should definitely go and explore.
Okay, Doppler is, handheld Doppler is a
And
good
also
option.
the pulse oximeter, sir, finger pulse oximeter.
Okay, right, thanks.
Thank you.
Call upon the next speaker, Padir. Padir? Aki. Your good name?
Sanjay Kumar Giri.
Okay. Sanjay Kumar Giri will talk on two-stage flexor tendon repair.
Yeah. Good morning, chairpersons and delegates. Topic is this two-stage flexor tendon repair. It is a retrospective case series of 15 cases. So what we, the zone 2, as you know, that it was a no man's land by Bonnell, and because of the poor outcome in range of the motions following the tendon repair in this zone. So in 1971, as we know that this Hunter and Salisbury published two-stage flexor tendon repair, a tendon spacer. They have used the tendon spacer in the first stage and a free tendon graft through the pseudo sheath developed around the silicon rod, which we all know in the second stage. So it is the mostly accepted treatment in the SCAD flexor tendons which come to us, our OPD in excuse me, after 6 to 8 months. So in our series, we have used this infant feeding tube and silicon tube like a spacer, as we are not able to get this Hunter's tube. So our aim was to evaluate the functional recovery of the patients with zone 2 flexor tendon injuries, and to evaluate the use of the hollow tubes as a tendon spacers. So when you go to the literature, we saw that these are the things: flexor tendon reconstruction in severely damaged hands, a two-stage procedure using a silicone Dacron reinforced gliding prosthesis prior to tendon grafting. Like this, clinical differences between nasogastric tube and Hunter's rod. First stage, zone 2 flexor tendon reconstruction. Ordinary PVC feeding tube, low-cost alternative to silicone rod. First stage, flexor tendon reconstruction in zone 2 hand. So, and also like the surgical outcome of one stage and two stage flexor tendon grafting in children. So, our study was between January 2020 to 2024. All the patients which we have included is about zone 2 flexor tendon injuries for secondary repair, and 15 patients, age was from 10 to 38 groups. Mean age was about 28 years, of which one was a woman and 14 were men. So of the 15 patients, mostly the caught were as the missing caught injuries, which is much, and also some are assault and some are prior TA. Right hand was mostly common, it is about 9 patients, and left hand was 6 patients. So interval between two stages is about the 1 month, and infant feeding tube or silicone tube were used. So this is a case one where child was a childhood trauma, stage 1 silicone spacer 10 French were used. Stage 2 we have used this, if you see in stage 1, you can see there is an index finger, right hand, there is no movements. And then we have used this palmaris silicone spacer I have used, and after this palmaris longus tendon was graft used for after removal of the spacers. In the second video, this is the after removing the spacer. Similarly, case 2, if you see, this is a pre-op case where we have, you can see in the left hand, the fourth finger is, there is no movement. Back, sorry. In stage 1, the silicone spacers was used, or in stage 2, we have used this palmaris longus. This is going, sorry. Similarly, in case 3, this is a 6-month history of RTA. And we have used stage 1 silicone spacer in 10 French used in the first stage. And in second stage, we have used this palmaris longus tendon graft after removing the silicone spacer. And if we see in the follow-up, you can see the movement has come out after using this. So evaluation was based on the score score adopted by those. We have used a method of Strickland method. The Strickland method was like PIP flexion plus DIP flexion movement minus PIP extension lag plus DIP extension lag into 100 by 175. This is the method by which you can know the consistency of the movement of the fingers. So patients were followed for up to the 1 year, and in two patients we have used these pulleys were used in 2, and remaining 3 it was reconstructed. As to in 12% it was intacted. So IPJ stiffness was observed in 4 patients on follow-up, which settled with active physiotherapy. So what by this method we saw that there is in 3 cases we have 75 to 100% Strickland formula, so that is excellent result. 5 is good. In 6 cases fair results, and in 1 cases it doesn't come out. So when we percentage, we found out that the result come out in 20%, good in 30, and fair in 40%. So coming to the discussion, we saw that older flexor tendon lesions, particularly in zone 2, are generally associated with complications of retraction of the proximal and distal end. Very difficult to get the adhesion formation and collapse formation of the osteofibrous canal. So in our series, all the patients followed an early exercise protocol, and therefore decent results were little achieved. So on conclude, I would tell that the secondary surgery of the flexor tendon of the hand remain a demanding technique, and the method is still low cost and produce functional outcomes that are comparable to those found in the literatures. So while still producing acceptable results, although we have a limitation of 15 cases, and use of silicone catheter and infant feeding tube as a spacer is acceptable alternative to Hunter's rod where it is not available. This is my team. Thank you.
Dr. Sandeep, do you notice any difference in the outcome of patients who had a pulley reconstruction and whose pulleys were intact?
Those who are because there are three cases where we have got excellent result, their pulley is intact.
Okay.
12 cases we have pulleys intact. In 3 cases we have to construct it. So that pulleys which we have made it, we found that the results are not so much of good.
But the protocol was the same for both?
Yeah, protocol was same.
What was the gap between the first stage and the second stage?
We have kept about 1.5 months, 6
1.5.
weeks.
At that time, what is the thing? Any passive movement is happening, or
We have asked gradually to start movement so that there should not be any adhesions. After 2 to 3 weeks, we have started dynamic movements.
Use the Brunner or a mid-lateral incisions?
Depending upon the cases, Brunner's
Cases.
we have mostly used Brunner's.
So do you see any difference in the outcome between Brunner and the mid-lateral incisions?
No, in that there is no. Only we have approached that extensor lag, that formula that we have paid it, that is DIP and PIP extensor lag. In that we found some cases where pulley has been made, whatever you have marked out, sir. In that cases, there was little bit of difficulty in movements. Then that those are intact.
Okay.
so? What do you suggest? No need for Hunter's rod.
Because Hunter, if it is available, it is all right. But Hunters is most places it is not available,
Yeah.
and it's also a little bit of costly. So
Problem is with the size. You have used
Ah.
10 French and you have used Palmaris longus. If you are going to use a FDS, you can use FDS also.
FDS, I have shown 2-3 cases Palmaris longus. We have also used FDS also.
If you are using FDS with the 10 French size, it becomes a problem because otherwise
Ah.
you have to do the vending of the pulleys also. Yeah, thanks.
Thank you.
A very good morning to one and all. My topic is about exploring the spectrum, a comprehensive study of pediatric hand injuries, epidemiology. Pediatric hand injuries are very important because of the ongoing development of the child's hand. So any injury can lead to significant deformity or disability or psychosocial problem. It constitutes about 2.3% of pediatric emergency and 19% of total hand trauma, and understanding the epidemiology of the pediatric hand trauma is very important because delay in appropriate treatment might result in long-term morbidity, and the time window for the intervention is shorter in children as the healing process is faster, so the deformity or disability may set soon. This is the retrospective study conducted between January 23 and December 23 of 473 children aging from 0 to 17 years who presented with hand injuries in our department, and injuries treated at other places at time of arrival, and injuries more than 48 hours, and major burns that are treated in specialized burn center were excluded from our studies, and follow-up period was maximum period of about 18 months. We analyzed the age group, sex, hand dominance, mode of injury, the risk factors, injury characteristics, number of digit involved, and injury level, need for surgical intervention, requirement for multiple surgical procedures, seasonal variations and its consequences. We found that male patient had predominance in our study population, and this shows the age distribution of our study, and interestingly there were 22 patients who were on 0 to 1 year. They were entirely dependent children. They were dependent on their guardians, and seasonal distribution shows that majority of populations had injuries in their holiday period when the children are free, and side distribution there was no significant variation. It was around 50%, and most of the case we saw was due to household injury like door crush injuries and all other household activities, followed by accidental fall while playing, and other injuries like chain sprocket, RTA, work spot injuries and cracker burst injuries, assault, burns and self-inflicted were other injuries. And this image shows a 1-year-old dependent child with major crush injury of the forearm, but this child landed in amputation because there was associated blunt injury to the abdomen. And this is another 2-year-old child with cracker burst injury, and this shows another sugarcane crush injury in a pediatric population where the children is not directly involved in the field, but because of the exposure with their parents, accidentally these crush injuries happen. And this image shows washing machine injury where avulsion of the index finger happened and landed in shortening and closure because the patient did not bring the distal part. And this is another 15-year-old patient with work spot injury. Children are still exposed to the industrial works in major part of our city. And these are some of the cracker burst injuries that were managed in our institutions. So regarding open versus closed injury, we had more number of open injury than closed injury, and with bony involvement, it was around 50-50 percentage, and most of the patient in our study, they required surgical management. And surgical management, it included the procedures like primary skin suturing, amputation, dislocation reduction, and other procedures as shown here. And we had 37 patients undergoing multiple procedures, and patients resulted in contractures, deformities as shown here. This is a patient who was managed for cracker burst injury, required multiple procedure for deformity correction, flap cover, yet the patient is waiting for syndactyly release for the fingers. Here also the patient has undergone contracture release and skin grafting. The patient who underwent flap cover had to undergo multiple procedures like division, delay, and then flap thinning and reconstructive options. Patients who were managed conservatively showed very well a good healing with molding. And this is the procedure, long aluminum splint traction for displaced phalangeal fractures. We have done for 3 patients. So all patients in our study were exclusively operated in proper operating theatre, and household injuries were more common in 0 to 8-year population, being the door related single finger injuries were more prevalent, and sports recreational activities were the leading cause in those people who aged 9 to 17 years. Fall while playing is the most common. With increasing age, the incidence of closed injuries rose, and the injury level moved proximally. Most of the patients in our study required surgical intervention, and proximal phalanx was most common site of the injury, followed by distal and middle phalanx. Closed fractures accounted for majority of all fractures, and extensor tendon injuries were more common than flexor tendon injuries. Notably, there were significant number of cracker burst and workplace injuries among our children. Most of the pediatric hand fractures did heal well with molding and splinting, but when physis is involved, it resulted in some form of deformity and growth disturbance irrespective of the treatment methods. And minor injuries and pain-free hand makes the child move it spontaneously, thus easier rehabilitation, whereas rehabilitation and splinting for deep wounds pose challenges in this age group. And so the guardians of the children be aware of the differences in trauma incidents, and patients as well as the children and parents should be educated about the safety of the hand. So we should formalize prevention strategies for each age group. Proper treatment along with rehabilitation at appropriate time is critical for pediatric hand injuries, and proper knowledge about hand injury should be emphasized to the general practitioner, and timely referral to the specialized hand center should be advocated. Thank you.
Okay, so this is an epidemiological study. So what way have you applied this knowledge in your practice?
Sir, we tend to teach our patients even when they come regarding these injuries, so at least they can prevent in further episodes. Mainly the cracker burst injuries we used to see a lot, so we explained.
Is it possible that your study, have you compared with other studies in India where it is comparable, or is it different spectrum?
Yes, sir, it is comparable. But the work spot and cracker burst injuries we have seen more when the other studies have been reported.
More of crackers in your place.
Sir?
Cracker blast injuries are more in your place.
Yeah, yes, sir.
Okay, thanks. Next speaker.
morning, everyone. I am presenting my study, the epidemiological study of pattern of hand injuries and their outcome in the patient presented to tertiary care facility in North India. Introduction. Hand injuries are common worldwide and are among the leading cause of financial loss and disability among the human population. This studies aim to determine the pattern of hand injuries and their outcome in the patient seen at our trauma center and the department. Objective of my study was to study the pattern of hand injuries and the patient seen at our center in the 8 months of duration. At this study, I am presenting my data for the 8 months, and it is my ongoing study at the institute. The secondary objective to determine the most common cause of the hand injuries, the severity of injuries using modify hand injury severity score, and document the type of definitive treatment offered. My method is, it is the prospective observational study that carried out at our center in the past 8 months. The target population was the patient who presented with the acute injuries. At this study, I am taking the sample size of 50, I am presenting the data of 50 patients. And in the data, I collect the causes of injuries, nature of injuries, severity of the injuries, the inclusion criteria, the hand injuries distal to the wrist I am taking, and the exclusion criteria of my study, the hand injuries due to burn, or the patient presenting with the chronic injuries, or have prior injury, and the injury proximal to the wrist. So, the result of my study, I compared among the age, gender, mode of injury, and the type of injury. So among the age, as we can see, the 76% of the age group was 20 to 50 year of age, which is the most productive age group, which cause the increase the economical burden. The most common injury is among the male, which is 82%. And the right hand involved with 64% of the patient, while the left hand involved in only 24% patient, and bilateral hand involved in the 12% of the patient. The most common mode of injury in my study was the mechanical injuries, that is 54%, and the secondary cause is the road traffic accident, that is 36%. Then the blast injuries, and which is 8%, and the 1% was the animal bite, that is 2%. The most common injuries are the crush injuries, 62%, and the second is the sharp injuries, that 26%, and the blast injuries is 8%, and the degloving injuries the 4%. The most common injuries occur at the night time, that is 42%, and the second most common at the morning time, that is 30%. The most common finger involved, thumb is involved in 32% patients, middle finger is the 22% patients, index finger in the 16%, and the least common is the little finger, that is only 2% of patients. Though among the treatment given, depend on the injury, the primary suturing was given in the 14 patients, skin graft was done in 3 patients, flap cover was done in the 6 patients, tendon repair need to be done for the 22 patients, fracture fixation was done in 17 patients, revascularization was attempted in 3 patients, stump closure was done in 9 patients. So according to the severity score, the most common injuries are mostly the minor type of injury, that is 38% of patient, and severe injury was in the 7% of the patient. In our study, the 50 cases, that is 82% was the male and the 18% was female. The finding is consistent with the most of other study that is have been conducted. These are the comparison. In our study, 86 patient was a sustained injury in the right dominant hand. The similar study finding was in other study also, Gupta et al. And crush injury, in our study, crush injury was among the 62% patient, which is equal to the, similar to the Hangatel. The conclusion, the male gender is the most prone to the hand injuries compared to the female gender. Hand injuries commonly occur due to the machine-related injuries being the leading cause. Road traffic accident are the second most common leading cause of the hand injuries, and majority of hand injuries fall under the category of minor, and with the severe head injuries constituting the least number of the injuries. So my recommendation for this study, the employer should enforce the training and the safety machine handling to reduce the machine related injuries. Machine operator include the shop cutter user should wear the protective gloves and the prevent to reduce the hand injuries, and the government should mandate the protective gloves for the motorcyclist to lower the motorcycle related hand injuries. Thank you.
Well-tailored study, madam. Can you define North India?
Yes, sir.
You said it's North India.
Actually, my college is in the tertiary care center at the North India. That is why my study is at
You
my
belong to which is your place?
King
madam?
George Medical College, Lucknow.
Lucknow. Yeah. Because of the migration, no, you are not going to treat patients from. It will be people from south also, but there is no landmark. I think it should be a center study of injury patients in your center,
Yes, sir.
rather than putting North India, because Manas sir is treating patients from all over the India. So it will not be exactly of North India. So I think that's a vague term. When you define or put a title for the study, that should be very precise. That's all. I like the way you have taken the timing as a factor. Most of the epidemiological studies doesn't take that injury happens at this time of the day. That's a good thing. Yeah, thanks.
Thank you, sir.
Morning. My topic is protecting the flexor tendon injuries following volar plating of distal radius. Volar plating is the gold standard for treatment of distal radius fracture with intra or extra-articular. The rare but a dreaded complication is flexor tendon injury post surgery. Most commonly, ruptured tendon is flexor pollicis longus. Our study aims to predict the ruptures based on the placement of the plate and to prevent such complications. Here we depict the volar plate placement and the FPL tendon running over it. Zoom classification has been used to estimate the volar plate prominence using X-rays and evaluate the risk of injury post-surgery. The study is done to evaluate volar plate prominence and predict the plate removal. This is a retrospective study conducted in our institute, and a total of 130 patients who underwent volar plating within the time period were included. And we excluded patients undergone K-wires or other surgeries, and a patient who had surgical site infections and which led to early plate removal. They were classified according to Zoom grading, and patients who had wrist pain or tendinitis-like symptoms, ultrasound has been taken. This is a picture depicting the Zoom classification. A tangential drawn from the volar lip of the distal radius and classified as 0, 1 and 2 according to the plate prominence. There is a watershed line which is the most distal part of the distal radius along the volar lip. All the patients were classified according to Zoom grading system and evaluated for wrist pain, difficulties in activities and weakness of the tendons. Flexor tendons integrity is checked by muscle power, and if he suspect the patient had tendon rupture, he took an ultrasound. This is ultrasound depicting the FPL tendon. And on our evaluation of 130 patients, nearly 10% of the patients had fallen into Zoom grade 2 classification and 46% into grade 1. And further evaluation, 13 patients had symptoms like wrist pain and tendinitis-like symptoms, and among those 13 patients, 8 were of Zoom grade 2, and only 1 patient had a rupture of FPL tendon. And plate exit were done in 7 patients, of which 6 patients had a pain for a chronic period, and 1 patient had a rupture. This is a case of left distal radius fracture managed with the plating, who fell into grade 2 Zoom, and but ultrasound showed normal and power were normal, but the patient had chronic pain, so the plate exit was done. And this is another patient with the right-sided volar plating. Ultrasound showed a functioning tendon, but since the patient had tendinitis-like symptoms, the plate exit was done. Here we have a Sung grade 2 type of fixation, where the ultrasound showed rupture and his power has also decreased. So patient has done implant exit. Due to heavy amount of fibrosis, we cannot proceed with further reconstruction. This is a grade 1 and the patient had only wrist pain. And as far as the literature review is concerned, Sung article shows that plate prominence may increase the risk of tendon injury, but whatever the surgeons should avoid the implant prominence in this area. And further analysis showed that tendon rupture occurred with grade 2 prominence. And a study by Vasara, a recent study showed that higher Sung grading is a risk factor for flexor tendon injuries and plate removal. And there is a early plate removal as in the Sung grade 2 is more than as classified in Sung grade 1. And Sung classification is a reliable classification as quoted. So my conclusion is flexor tendon rupture is actually a very rare complication. It to only 1%. But if you use Sung grading to classify, you can predict the fracture. And fixation of distal radius proximal to the watershed line prevents these complications. So we have to place the plate proximal to the watershed line, and suturing of monitor quadratus of fat interposition may help. And usage of low profile plate and fragment specific plate can be used which will not irritate the tendons. The limitations of our study is only a retrospective study, so we cannot consider intra-op difficulties and what has been done intra-op. And the type of plate used are not uniform in our study, and we have any small sample size. So further study based on the type of plate can further increase the accuracy. And these are the purposes. Thank you.
Can you show the first X-ray which you were showing in this? Yeah, no, yes. Is the caviar inside or outside?
It's inside only, sir. It's actually touching the volar cortex.
So, did you consider the factor like if the fixations were acceptable or not? I mean, like, were there tendon ruptures were more in suboptimal fixations?
In a case where flexor tendon was ruptured, actually it was so prominent and it was not.
No, I'm not about the plate prominence. I'm asking about the anatomical reduction.
In this study, we considered only the plate prominence. Sir. We didn't consider.
There is no pre-op X-ray. So why? Because plate configuration of fracture and putting a plate on seeing the pre-op X-ray.
Yes.
So if it can be managed with a fragment specific plate or KY, because we don't have a pre-op X-ray. So you should put a pre-op X-ray also, no? So that
yes.
It can be treated by another way of method.
So what sir wants to say is that there are different methods of fixation of distal radius fractures. If you are looking at the tendon rupture, you can go for KYs. KYs also is a different method. External fixator
Yes.
is also a different method. But plating, we always see this sort of a complication, especially if you have a more distal fractures where you keep the plate more beyond the watershed line, what you said.
Yes.
So what is your take-home message that if you see that there is a zone grade 2, grade 3, what do you suggest to the patient?
The patient had some grade 2 classification which should just educate the patient whether he have wrist pain or some weakness of symptom. We have to exit the plate and further.
So you constantly do ultrasound and evaluate them, or will they come with a problem?
So
It's best is to educate the patient that see there is a problem you might have, so be careful. One
Yes.
thing. How early have you removed the plates?
6 months. Project.
6 months.
6 months.
Anything else? Yeah, thanks.
Thank
We go on to the next speaker, Dr. Navneet PK.
Good morning all. The topic on a treatment algorithm for operated distal radius fractures with concomitant ulnar xyloid fracture, a pilot study. Ulnar styloid fracture occurs in approximately 55% of all distal radius fractures. However, the functional outcome of these fractures after fixation remain indefinite. The most symptomatic DRUJ conditions result from derangements to several structures, which include the distal radius fracture pattern, level of ulnar styloid, and the displacement of ulnar styloid, and the DRUJ instability. So in literature review, we found that functional outcome of untreated ulnar styloid fracture after distal radius fixation have no significant difference on functional outcome. However, another study by the Kramer shows that the ulnar styloid fractures having higher pain scores, higher rate of DRUJ instability, and greater loss of motion and poor functional outcome. So the different parameters to be addressed during DRUJ stability includes distal radius fracture pattern, DRUJ stability, and level of ulnar styloid fracture and ulnar styloid displacement. Hence, to correlate the clinical radiological outcome of surgically fixed distal radius fractures with ulnar styloid fractures for developing a treatment guide. The clinical outcome was assessed by range of motion and intraop allotment test, and functional outcome by PRW, QDASH, and VAS score, and radial by ulnar styloid displacement on pre-op and post-op X-rays. It is a prospective study of consecutive distal radius fractures with concomitant ulnar styloid fractures operated using molar locking plate, and the DRUJ instability was treated by either cast or application or K-wire fixation. Distal radius fracture pattern was classified by Frickman classification and ulnar styloid by Golke classification, and displacement was measured in pre-op and post-op X-rays, and DRUJ instability assessed by intraop allotment test. We include the consecutive distal radius fractures with concomitant ulnar styloid operated using molar locking plate with adult patients ranging from 18 to 60 years. And we excluded patient underwent fixation of ulnar styloid fractures and bilateral wrist fractures and previous injury or surgery to the affected wrist and pathological fractures. We assessed the distal radius allotment test. If it is positive means the displacement of the ulnar head or a lack of endpoint resistance when compared to the opposite side, and the range of motion we assessed the flexion, extension, and supination and pronation. And this is the Golke classification. Type 1 is tip and type 2 is base, and we assessed the displacement of pre-op and post-op using X-ray by Meyers method. And the demographic, our pilot study having included 22 patients with average age of 39 and more being left side affected patients, and RTA being most common mechanism. And comparing the different parameters with the functional outcome, we found that intra-articular have poor functional outcome in terms of VAS and PRW score. However, DRUJ instability have no correlation, no statistically significant in the functional outcome. Ulnar styloid base fractures have poor functional outcome in terms of VAS, PRW, and DASH score. However, ulnar styloid displacement have no correlation with the functional outcome, both pre-op and post-op. This is one of our case with the 2 months follow-up X-rays after fixation. And this is another case with the 2 months post-op. This is a Frickman type 8 fracture and after 2 months post-op X-ray. And this is another 7 years follow-up with intra-articular fractures showing good functional outcome. And the literature review comparing one study with systematic review and the other randomized control trial which showing the unstable and stable DRUJ. It shows that no statistical difference in functional outcome between fixation or non-operative treatment of ulnar styloid. And another study which included ulnar styloid fracture in treated distal radius fractures shows that there is no additional surgical fixation is not needed in case of ulnar distal radius fractures which fixed with the plating. However, another study by the Logan shows that ulnar styloid should be fixed irrespective of DRUJ stability if it is a base fracture of the initial displacement is more than 2 mm. And in the distal intra-articular extra-articular fracture comparing it shows that the presence of ulnar styloid fracture did not predict any change in the personal patient reported functional outcome. Hence, we concluded that the extra-articular distal radius fractures and the ulnar styloid tip fractures having good functional outcome. However, larger studies will bring out more significant of these parameters, and hence we are providing an algorithm and checklist so that we do not miss out of these parameters to get a good functional outcome. Thank you.
So based on your observation, what do you suggest that we should fix or you don't want to fix?
Sir, if the intra-articular fracture, if we are after fixation with the volar plating, we will check the distal radial DRUJ stability, and if it is a base fracture, we can consider fixation.
No, it's not can consider. You suggest that based
Yes, sir.
on
We
your
are suggesting
observation.
we can go for ulnar styloid base fracture fixation. Tip we are not suggesting, but base we can fix either directly or indirectly through DRUJ fixation, sir.
You have done any arthroscopy in the
No, sir, we
plating
have not done arthroscopy. Thank
What
you, sir.
size wires you use for the radius?
Radius, in case of styloid fractures for fixation, we use K-wires, sir.
What size?
1.5, sir.
For the radius, what size you use generally?
Generally 1.5.
1.5.
1.2 mm to 1.5. Sir. Thank you, sir.
Good morning, everyone. My slides. Good morning. I'm Shilu Shrestha. I'm an orthopedic hand surgeon from Kathmandu, Nepal. First of all, I want to thank the organizing team for inviting me as a faculty, and I feel very honored to be presenting our work in front of all of you. So I'll be talking about the gap non-union of the upper limb, which is a challenging injury to orthopedic, plastic, and the hand surgeon. The most common causes are the high energy trauma, infective non-union, failed primary fixation, resection of bone tumors, and the gunshot injuries. So there are various management options explained from cancellous to corticocancellous graft, vascularized or non-vascularized fibular stirred graft, distraction osteogenesis by the ring fixator, and the masculine technique. We present our series of 31 patients. The average age of the presentation was 33 years, mostly male, and the most common cause was the infective non-union and the failed primary fixation. And the most common reason was the forearm. We undertook various surgical options, the most common being the masculine in the recent years. Few of our case examples is a 14-year-old boy who had a forearm injury while he was 5 years old and presented to us with this deformity and inability to flex his fingers. This was his X-ray. So we opened the non-union site to release all the tendons and fix the fracture with the acute shortening. He was from a very remote place, so he never presented for the follow-up. So we recently contacted him for this presentation to send us some clinical pictures. He said he's more functional than before and he's using the hand as an assistive hand. Another boy, 19 years old, presented to us with this deformity because of the injury happened 6 years back. He had a neglected Montesia fracture dislocation. We opened the non-union site. We decided to do the double onlay fibula stud graft. This is after fixation, 8 months after the fixation, and these are his recent clinical pictures. 21 years old lady with a distal radius fracture. It was an open distal radius fracture. She underwent multiple surgeries and presented to us with the gap in union of the distal radius with the deformity. We stretched the soft tissue with the external fixator and later fixed with the free fibula graft with partial arthrodesis of the wrist, and these are her clinical pictures in 1 year time. So this is 46 years gentleman with the open humerus fracture covered with the LD flap and underwent multiple surgery for the fracture fixation, presented to us with the gap non-union, and we fixed it with the proximal humerus plate with the bone cement and cancellous bone graft after 2 months. These are his subsequent x-rays, and these are the x-rays in 1 year time. Another gentleman with the road traffic accident with open distal radius fracture associated with other multiple injuries. The distal radius was fixed with the external fixator, and later we fixed it with the distal variable angle locking plate with the bone cement, and these are his subsequent x-rays. This is the x-ray at 1 year time. These are his clinical pictures, and he's still doing his physiotherapy. Lastly, 40-year gentleman with a closed both bone fracture fixed with a plate, got infected and presented to us with the gap non-union like this. We opened the non-union site, debrided, and there was an 8 centimeter gap in both bone. So we fixed it with the titanium elastic nail with some shortening, and later did fixation with the locking plate with bone graft. This is X-ray at 1 year time, and these are his clinical pictures, and he is working as a security guard in India. So the successful management depends on the soft tissue envelope, size of the bone defect, type of the non-union, and the presence of infection, and also depend on the resources you work with and the expertise you have. Thank you so much, and I would like to take this opportunity to welcome all of you to our country, Nepal. Thank you.
Do you have any protocol like for the forum, like if this many gap you will do, you do this, I mean?
No,
Or
no, we don't have any specific protocol, but it all depends on where the patient is coming from, the size of the defect.
You mentioned about masculate technique. Have you had any cases? You have not shown any case.
Sorry?
Masculate technique, you're used in the forearm also or only for the humerus?
No, also for the forearm. I showed the last case was on the forearm.
Forearm, okay. Right. You used any distraction methods for any of your
Not for
cases?
the upper limb.
Not for the upper limb. Yeah, thanks.
Thank you.
With this, we have come to the end of the free paper session, and I thank all the people who had come forward to present it, and over to the next. Thank you. Thank you very much.
thank you.